Hello and welcome to this episode of our Rhinoplasty for Residents and the Foundations of Facial Plastic Surgery webinar series. We really hope you have a great time watching this show.
I'm in southern New Hampshire right now, about 4 hours north of New York City, for those of you who don't know where that is, and an hour north of Boston. So it's a beautiful midsummer day for us, perfectly clear and lovely weather. Not enough rain. If you're trying to grow grass, you can't grow it. What I want to do is try to give you a quick review of as much as I can fit in of research I've done over the last 8 years, and the real heavy duty research. And before that, a number of years of trying to figure out what was going on, why I couldn't make certain patients happy, even though they should be happy. You know, we all have, fortunately, patients who we're not happy with in the results, but the patient loves it. And thank God for those patients. But there, you also get the other way around, where you think you've done something spectacular, and the patient is very upset, even with results that should have achieved their goals, and they either hate the surgeon or hate themselves or both. My screen and tell you how I think about this right now. As Cam said, please no photography or no recording. I get royalties for this book, but they all go to charity. I don't make a penny on it. It is a very heavily researched book, so there's 830 references in here. Plus, I go through a lot of the stuff I'm going to discuss with you today in great detail. As I began to explore this literature, I realized that the body image literature people didn't talk to the body shame people, didn't talk to the body dysmorphic people, didn't talk to the PTSD to people, didn't talk to the childhood abuse people. And so I've tried to pull all of that together as a resource for surgeons and patients alike. So I don't want this to sound like a shameless plug. I'm really trying to get education in something that none of us know very much about. What has always bothered me about, and still does, about the mental health approach to body dysmorphic disorder is that there is very little curiosity about where it comes from. Almost nobody is trying to figure that out. And that upset me from the beginning and still does. Then the DSM-5, which is the psychiatric manual in the United States, defines body dysmorphic disorder right now as preoccupation with a perceived deformity, something only the patient can see, but there's something that upsets them terribly. And they do various kinds of things to camouflage the deformity. Now, there have been searches for genetic abnormalities, for neurotransmitter abnormalities. They've all come up dry so far. So this is still an idiopathic disorder, even though it is very common. Up to 20 or 30%, depends, up to 50% in some surgical groups, depends on whose study you're looking at, and about 2% in the population. The treatment, conventional treatment, is cognitive behavior therapy and antidepressant drugs. But the results aren't that exciting. I mean, they're 50% improvement over 6 months. I mean, that we wouldn't accept that in any other kind of disease, but that's okay. That's the best we can do so far. Now, that doesn't describe the patients we see. We don't take care of the delusional housebound patients that go to mental health people. Those patients have already had a diagnosis made and they're looking for help. We see patients who want surgery or want more surgery, but no matter what we do, the revision rate is higher, the requests for revision are very high. So in our world, that's BDD, the perfectionistic, demanding, depressed patients who've had lots of cosmetic surgeries, and no matter what we do, we can't make them happy. Now, this is the way I see these patients. We see them before surgery, lots of surgeries, a history of needing revisions and now coming to you for more revisions. They are not compliant often. They don't show up for lab work. They don't show up for appointments. You can't examine them. They get very squirmy and miserable. And after surgery, as I mentioned, they're disproportionately upset with a result that met their stated goals. They will be untrusting without justification. Patients used to say things to me like, "You betrayed me," which is a very odd thing to say to your surgeon. I never understood it. Now I'm beginning to make sense of it. They want endless revisions of trivial imperfections. You can lay out the photographs and tell them that what they see doesn't exist. They don't believe you. And they will say, or post on the internet, hostile, very distorted thoughts. This is the kind of thing patients have said to me. And I've got a lot of vignettes in the book of the interactions I've had. If you're depressed about your interactions with your patients, I guarantee you'll feel better after reading the ones I have. I want to thank you for ruining my life. I trusted you, but you betrayed me. You deceived me and then you experimented on me once I was asleep. What you've done to me is criminal, one woman said. One woman posted, this man is a butcher. He's abusive. He smashed my nose into his face. And then she said, I haven't been able to read since he operated on me. I think that's fascinating. And she posts herself as the walking dead. One woman said to me, you have taken away my friends, my family, and my joy in living. Now, this is preposterous stuff if you're talking about a rhinoplasty. Some of this, I want to thank you for ruining my life. That's what your teenage daughter says to you about her boyfriend. It's not something an adult says to her surgeon. So back in the 90s, I operated on 3 patients who had very good results. I mean, so good I could have put them in any of my instructional courses because they exemplified good treatment of the way I think surgery, rhinoplasty ought to be done. But they were devastated. One was a university professor who became a recluse in her house and stopped teaching. She'd only shop for food in distant places where people wouldn't recognize her. She wouldn't let her family visit. One was a doctor's wife who became a recluse in her bedroom and stopped taking care of her family. The husband begged me to operate on her again when there was nothing else to do. And one man tried to amputate his nose with a razor while I was away at an ASPS meeting. Fortunately, he only lacerated the skin, but all these people thought they were severely disfigured. And if I felt comfortable showing you their pictures, I don't think you would agree with them. So I went to the literature, but it didn't help me. It described BDD the way pneumonia was described by Osler, all the signs and symptoms and no pathogenesis. And then I had a patient who came to me and said, I had body dysmorphic disorder, but I'm all better now. And I really liked him. So I said, with the permission of your therapist, I'll operate on you. And I did. And he was a very easy patient. I still have contact with him. And afterwards, I said to him, if I write you a letter that asks you a bunch of questions, will you answer them for me? Because most surgeons never meet anybody like you who's had body dysmorphic disorder. He said, sure. So I sent him this letter and he sent back a 4-page, single-spaced autobiography of a horrendous childhood, a brother who committed suicide, how he described how he'd got body dysmorphic disorder and then was operated on and then given a bunch of medications and had idiosyncratic reaction to some of the psychotropic drugs and ended up on a ventilator and then ended up in a halfway house for schizophrenics. And right at the last page, he says, I suddenly realized that my problem was not my nose. It was that I was a 30-year-old man who never finished school and didn't have a job and didn't have a girlfriend. And I was going to live in places like this forever unless I did something about it. Now that to me is an epiphany that is unique among all the BDD patients that I have ever treated. But there's a place in the letter where he says, at age 7, my stepfather submitted me to photographs only to show me that there was something wrong with my nose. First, as a child, he resisted this, but the stepfather kept going at him and at him and at him. And eventually he gave up and he said, I decided my stepfather was right. And so I thought, all right, in this one person, at least, there's a connection to childhood abuse that BDD just doesn't, maybe it just doesn't start suddenly at ages 12 to 14. Maybe something starts before that. Right now in mental health, the picture is that these patients are like perfectly normal and everything is wonderful in their lives till suddenly they become obsessed. And then their self-esteem goes down and then their family lives disrupt. And then they develop other associated disorders, obsessive compulsive disorder or social anxiety disorder and depression. And the worst ones attempt or commit suicide. And that's why that's the story. And right now, in the mental health community, the literature, well, I don't want to I don't want to attack mental health. The literature, let me say, the people investigating this are satisfied with that answer. So I looked at a group of 20 revision rhinoplasty patients that I had that all struck me to be the same. And when I look back at their original unoperated photographs, I always have my staff ask patients to bring in pictures of what they looked like before they had surgery. It's a good discipline for all of you who are rhinoplasty surgeons, because it'll tell you where the deformity came from. And when I saw these patients, a lot of them had normal noses, totally normal, straight, no imperfections, no asymmetry, no breathing problems, no bump. And I'd say to them, so why did you have surgery? All these patients were demanding, they were depressed, they were perfectionistic, they'd all had multiple rhinoplasties, they'd all had multiple other cosmetic operations. Many in passing told me about some kind of adverse childhood experiences, and my success rate in operating them was very low. And they answered that question by saying things like, my mother wanted me to be as pretty as my sister. My father said I was the ugliest baby he ever saw. My mother wanted an abortion, but it was the 50s and she had to raise me because I looked like an animal. I never heard a patient say that ever, except once, because my mother was so beautiful and I wanted to look like her. And one man said to me, I had surgery so people would love me. Now, these obviously are not surgical indications. So I thought, all right, I've got to pull on this thread a little further. I published in 2014 a couple of papers that I don't know if anybody read but me. I thought they were going to change the world, but it didn't matter. In PRS, entitled Why Some Patients Are Unhappy. And I had looked at 100 consecutive revision rhinoplasty patients of mine, 50 who started off with normal noses, and 50, meaning no bump, no asymmetry, no airway problems, and 50 who had dorsal humps. And in the 29 who had surgery for noses that were not only straight, but totally normal, and the patients knew they were normal, it was the same thing. The childhood abuse or neglect prevalence was over 90%. And my success rate, meaning making these patients totally happy with one operation where they didn't want any revisions, was only 3%. And so I thought, all right, that's surgical body dysmorphic disorder. These patients know there's no problem. And that's the definition of a slight or invisible flaw. And yet they have surgery. And then I started seeing things like this. This was a rhinoplasty patient. When I undraped her to prep her rib area, you see the scratch marks on her breasts. She was cutting her breasts. Of course, I never could get a history about her. She was so walled up, she wouldn't tell me. But cutting has almost 100% history of childhood abuse or neglect, often sexual abuse. So the most recent research that I'm just finished writing up now is a group of 218 consecutive postoperative patients. The first 175 are in the book. So I'm going to give you more additional information now. These are postoperative patients, and I selected them because I wanted to know these people. You can't ask these kinds of personal questions as an intake form and expect it to be reliable, because patients think there's something at stake. They want surgery, so they're not going to answer it. Or they think it's too personal, and why does this guy need to know this? So these are already people who know me and who trusted me, and I operated on them. And also I could put the findings in perspective. I could say, okay, these patients were very demanding. These patients wore out the staff. These patients needed all kinds of extra pain medication. And I knew a lot about their health history and so on. We gave them the Adverse Childhood Experiences Questionnaire, which is currently still the CDC standard in the US for childhood abuse and victimization. I collected, of course, health and demographic data like you all do, and then the body shame component of the experience of shame scale, which I'll tell you about in a minute. Now, the original Kaiser Permanente study was done in the mid-90s, and books have been written about it. There's a lot about it on the internet, and yet most people don't know about it unless they're trauma researchers. A lot of mental health therapists have never heard of it when I lecture to them. It's a pity because it's fascinating information. These were 10 questions these medical physicians made up at the Kaiser Permanente group. They weren't looking at this with childhood abuse experts. They just picked out 10 things that they thought would be worth asking about. Were you verbally abused or humiliated in your family? Were you physically abused? Were you sexually abused? Did you feel like nobody cared about you? Emotional neglect. Did you have physical neglect? Not enough to eat or wear, nobody to protect you, nobody to take you to the doctor if you were sick. Were your parents divorced? Was your mother physically harmed, violence against the mother? Did you have alcohol or drug abuse in the family? Did you have mental illness or suicide in the family? Did you have a household member that's imprisoned? Now, if you look over that list, my guess is many of us in the audience have had at least one of those things. They're not uncommon. When I have said to people recently, I'm reviewing and studying childhood abuse, everybody kind of shudders, like the only thing I'm just thinking about is sexual abuse. I'm not. I'm thinking about all of these things, and they are very common in society. Now, their patients were mostly middle class, mostly white, 10% Black, 10% Asian, employed patients with good jobs, or they can't get Kaiser Permanente insurance. So this was not a disadvantaged population. My group was 86% aesthetic, 14% reconstructive, mostly cancer patients. Again, not a disadvantaged population. 70% had college degrees or better. Surveyed for major childhood abuse or neglect, those 10 questions. In the Kaiser group, this general medical population, at least 63% had one answer. They were stunned by that number. They would have thought it was going to be much lower. In my patients, it's 80% overall. Now, in my reconstructive patients, it's 61%. And those data, question by question, were almost identical to the Kaiser data. But in my revision rhinoplasty patients, it was 85%. And this is how the numbers broke down. You can see in my group, 4 times as much emotional abuse. You're stupid, you're ugly, you're never going to get anywhere. How come your grades aren't better? Emotional neglect, twice as high. But look at sexual abuse, 23% in my patients. If anybody had said that to me, I never would have believed it a few years ago. Alcohol or drug abuse in the family, 50% higher. Mental illness and suicide, again, significantly higher. These are the 4 areas. And if you look at the others, they're almost identical to the Kaiser numbers, almost to the decimal point. Just like the Kaiser group, the more ACEs you have, adverse childhood experiences you have, the worse your adult health. That's what they found. There's a linear dose response correlation in my patients to hypertension, high cholesterol, obesity, cancer, drug abuse, chronic pain, somatic illness, irritable bowel. They also found it to heart disease, even without risk factors, and multiple other things like primary pulmonary fibrosis and multiple sclerosis. This is the advantage of having a huge 17,000 patient database. Depression in my patients was 56%, 3 times the US average. That is self-diagnosed depression. That's not measured. But this one was interesting to me because since most of what I do is rhinoplasty, I give a very set postoperative prescriptions, not much pain medication, and almost nobody ever calls and asks for more medicine. The people who burn through their drugs in 2 days and call up saying, I'm having excruciating pain, are unusual. And so they're marked and they'll ask for more pain medication. And many of them had drug abuse history. Now, if you look at the cosmetic patients, for the mean ACE, the average ACE score, the ACEs more than one, the prevalence that had at least one ACE, the number of cosmetic surgeries, the percent that were satisfied, the percent that wanted revision, the health, the number that were on antidepressants and recreational drug use. For the first 5 are all higher in the cosmetic patients than they are in the reconstructive patients. So I thought, okay, that's what I thought. I thought, all right, now I've got proof for surgical body dysmorphic disorder. Patient knows the nose is normal. So that's the definition of a perceived or slight defect in the mental health literature. Saw a surgeon, that's significant distress. And had surgery, that's compensatory behavior. That's the 3rd leg of the DSM-5 diagnosis. So I looked at the patients divided by the shape of the original nose. And what upset me was the numbers were identical. They shouldn't be. If patients start out without a deformity, they ought to fill those criteria that I just showed you. And they ought to be much crazier than the patients who originally had dorsal humps or airway obstructions or post-traumatic noses, but they aren't. They're identical in number of surgeries, in satisfaction rate, in requests for revision. And this, I couldn't figure this out. And then I thought, maybe the mental health literature is wrong. Maybe it has nothing to do with whether you have a deformity, because the data on revision patients who had normal noses ought to be very different from those who had deformities if having an invisible deformity were the key defining factor. Maybe the absence of deformity isn't what separates BDD patients. The ubiquitous outcome of childhood abuse or neglect is shame. There's something wrong with me. I was criticized a lot, but I wasn't a very good child. I was beaten, but I deserved it. Children don't blame their parents for what their parents do, particularly when they're very young. They blame it on themselves. They have to interpret their environments. You know, my parents got divorced, but it was my fault. I was sexually abused, but my abuser said I egged him on, and so on. My mother was mentally ill, or my father drank, but I caused it. So that's shame. There's something wrong with me. I'm a defective person. I am worth less. Maybe shame is the divider. Maybe it's how you feel about yourself. Now, there's three kinds of shame in the mental health literature: characterological shame, the way I am as a person; behavioral shame, the way I act; and body shame. And this was like an enormous epiphany. I read this, I would just get up at 4:30 and I'd read the stuff first thing in the morning before I went to surgery. And I read this paper saying that body shame was the most common kind of shame that came out of childhood trauma. So I ran upstairs to my wife, who was putting on her makeup and couldn't care less at 6:30 in the morning about what I had read, and said, "You won't believe what I just discovered. This is the link. If kids have shame and it becomes body shame, and they decide reason I feel awful is because of the way I look, that's the link to plastic surgery." So, all right, I started chasing that down. The body image component of the experience of shame scale is just 4 questions, and it's very easy. You hear this from a lot of your patients spontaneously, but I asked all of my patients this, and if they answered or if they didn't volunteer it, I asked them. If they got all 4, then I called them shamed. In the original study, they only had to get 3 out of 4. But have you felt ashamed of your body or any part of it? Have you worried about what other people think of you? Have you avoided looking at yourself in the mirror? Do you try to hide or conceal part of your body? Now, some of this correlates with what's in the DSM-5 for BDD. And when I divided the patients who had shame to the patients who didn't have shame, I had collected this information but never made much of it. All of a sudden, things changed. The mean ACE score was much higher. The percent that had at least one ACE was much higher. The number of cosmetic surgeries was almost double. Satisfaction rate was half. The requests for revision almost double. More health problems. More patients who described themselves as perfectionist. More patients who were on antidepressants or described themselves as depressed. And 15% had a history of drug or alcohol abuse. That was the dividing line. It had nothing to do with the shape. It had to do with how patients feel about themselves. And that was just the rhinoplasty patients. When I looked at all 218 patients, threw in all the reconstructive patients, all the non-cosmetic rhinoplasty patients, facelifts, the eyelid surgery, and so on, it was the same thing. I'm not going to read these numbers to you, but you can see how much higher they are. 3 times as many cosmetic surgeries, those numbers are reversed. They're much younger. They were 31 instead of 41 at the time they had their first operation. Lower satisfaction rate, much higher number, 3 times as many requesting revisions, more health problems, more perfectionism, almost 4 times as much, twice as many on antidepressants, and three times as many with a drug abuse or alcohol abuse history. So I figured, okay, this is a key to me. This is surgical body dysmorphic disorder. And when we did by logistic regression, we looked at all our variables. It had body shame, not the presence of a normal nose, not depression, not health, not perfectionism. All of those played in a little bit, but body shame was the biggest determinant of whether patients wanted another operation or not, reconstructive or cosmetic. Body shame patients were 4.6 times as likely to request another operation and not be happy with what I did the first time as unshamed patients. So this is the way I put this together. Now, all trauma creates body shame. There's something, I'm defective. Body dissatisfaction is different, but if you become body shamed, plastic surgery is the obvious solution. Now, I'll explain to you in a minute why these patients behave like they do. But when these patients come out of the surgery and don't feel better, they're going into the surgery not because of the deformity, they're going into the surgery to feel better about themselves, to feel like the surgery will fix about them what is defective. They come out and they still feel defective. They return right to the wounded child. They begin to hate themselves or hate us both. Now, this happens all the time in real life if you look for it. Let me give you an example. I was in overseas at a meeting, and I was about to go to Germany to operate. So the lab was sending the lab work in from Germany into my office, where my secretary was collecting stuff. My nurse was gone, I was gone, my wife was gone. So the lab work comes in and it's in German. So she writes me this hostile note saying, I wasn't hired to speak German, all in capital letters. I mean, of course you weren't. You're hired to be my secretary. I thought, I'll fix it when I get home. The surgery's not for a month. What happened? This woman I know came from a very dysfunctional family. When she saw that, she didn't think, oh, well, it's in German. I'll give it to him when he comes in and not my job. She thought, I'm worthless because I don't speak German. I'm defective. So she got mad at me because I made her feel like this. Her brain thinks, I feel awful about myself and I have to find a reason for why I feel awful. But as the cortex comes online, you lose those connections to the midbrain where all the damage gets done. So she got mad at me. I became the reason she was angry instead of blowing this off. These are very common situations if you look for them. So this, I think, is surgical body dysmorphic disorder. Now, body dissatisfaction is different. Our best patients have body dissatisfaction. They don't like their noses, for example, because it's got a bump, but they know they're worthwhile people. These are functional people of happy lives and happy families, and they've got pride in themselves. And the bump is just like this annoying thing they want to fix. That's different. Body shamed people feel defective. And the reason they feel defective is because of the way they look. So you can't fix this with surgery because surgery is not, the indication for an operation is not surgical. It's emotional. This is emotion driven. So let me tell you a little bit about body image now. Body image, and the body becomes a home for the things that happen to us, the adverse things that happen to us in our lives. That's the rationale for a lot of mental health therapy, what's called somatic experiencing. Shame and things that happen to you get stored in the body. Freud said the ego is first and foremost a body ego. We know that stress, unrelieved stress, can cause illness. You know, we all know about angina, heart attacks, migraines, ulcers. Somatic illness is the same way. Patients with diseases you can't explain, they go from doctor to doctor because nobody can figure out why they still have back pain or why they still have headaches. Or if you remember from general surgery, post-cholecystectomy syndrome, where you've had your gallbladder taken out, but you still got gallbladder pain. This is somatic illness. So poor image is associated with low self-esteem, well-being, poor well-being, and perfectionism. This is all in the mental health literature. And once you develop this idea, there's something wrong with the way you look, it never gets better. Boys, interesting, tend to ignore negative comments. They don't focus on their bodies so much, but women do much more. And in the mental health literature, this is the kind of sort of circular reasoning that stays in the body image literature, for example. We have the same things in our specialties. We say the same myths over and over to ourselves, and like, even though they don't always make sense, we keep saying them again. So in the mental health literature, they say the women have eating disorders because of media pressure because of thin models and Barbie dolls. And so I said to my wife, then why don't all women have eating disorders? They're all on the media. And if the media is so all powerful, why are so many adults obese? Why isn't everybody thin? It doesn't make sense. But in the mental health literature, in the body image literature, this is like, okay, QED, we figured it out. It's the media. So women make the next step to body shame from body image. Many women who feel bad about the way they look translate that into, I'm really an inferior person. And so like body dysmorphic disorder, eating disorders, obsessive compulsive disorder, body image issues occur in families. And 20% of patients with body dysmorphic disorder have a first degree relative who also has BDD. Now look at how much we made out of that because it occurs in breast cancer, and that this is being ignored in the mental health literature. Trauma is never mentioned in the literature as a reason for why this might run in families. They search for genetic abnormalities, can't find them, and give up. Now this is actually one of our daughters-in-law and one of our granddaughters who's actually turned 10 years old today. That's how old this picture is. But the reason this picture makes you feel good is because the mother and child are making eye contact. At eye contact, nurturing, the way infants and young children are cared for at a very young age determines how the whole stress mechanism and the whole hypothalamic pituitary axis and the whole epigenetic makeup of the adult occurs. So this is the connection to adult disease. The more trauma you have, the more health problems you have as an adult in the Kaiser study and in mine. So it determines levels of neurotransmitters. It determines the size of the orbitofrontal cortex, the executive part of the brain, whether you can soothe yourself or not. If a baby starts to cry and the mother picks it up and rocks it, pretty soon the child learns to calm himself or herself. If that child is ignored because mom is depressed, mom is drugged, mom is too busy with other children, there's no parent there, an older sister is looking after her, that child learns something about the environment and never learns to calm themselves down. And you've all have patients like this. They're anxious, you answer all their questions, and then they call back half an hour later and ask your nurse the same questions because they can't even remember what you told them to relax them. They can't soothe themselves. They learn how to trust. If you're a baby and you cry and someone rocks you or feeds you, or you're a baby and somebody slaps you because you're making noise, you learn very different things about the world at a very young age. What are big people like? Are big people the enemy or are big people my friend? How important am I? What happens to me if I express displeasure? Do good things happen or do I get pain? So right early on, we begin to formulate these ideas. Baseline cortisol levels are affected. These are genetically transferred. It's been shown in animals. Cortisol levels carry through to the infants if the mother is stressed during pregnancy. The hypothalamic pituitary axis becomes less stable and behavior changes. So I'm going to tell you something that I think fascinates me, and I think you'll see this too. Don't go to sleep because this is neuroanatomy. There are two vagus nerve nuclei. And remember, the vagus nerve is 80% afferent. It is an information nerve, not just the longest nerve in the body. It's the information nerve. It's not, we tend to think of it as efferent to the heart and the lungs and the bowels and so on. It is mostly afferent. There are two nuclei, the dorsal motor nucleus of the vagus. That's the more primitive one. We share that with all the lower animals. It is unmyelinated, it is primitive. We share it with reptiles. We share it with all the submammalian creatures. And it is all subdiaphragmatic, almost all subdiaphragmatic. And it is what we call on for survival. The nucleus ambiguus is only in mammals, and it is myelinated, and it transmits much faster, and it is supradiaphragmatic largely. And it has connections not only to the heart, but to all those cranial nerves. So when the nucleus ambiguus is stimulated, when that's dominating, our hearing gets sharper, our facial expressions become more animated, our voice, prosody of our voice, the pitch of our voice changes. And these systems are used in order. This nucleus ambiguous affects your heart rate. It inhibits fight or flight. Now, the next thing, if this nucleus ambiguous system is stressed and you go into fight or flight, that drops out. That's why patients stop listening when they get upset. They're now in fight or flight. And when that drops out, they go into the restorative mode. So when you're doing something to a patient, I used to mark breast reduction patients the day before surgery. And some of them would say, I'm just using a marking pen. They'd say, I'm feeling faint, I'm gonna throw up. That's the dorsal motor nucleus of the vagus. That's restorative. That's all lower diaphragm. That's basic survival. Something in their brain is telling them, you're gonna die from this operation. That's why that's happening. So this is an animal playing dead when the hyena chases it. That's the dorsal motor nucleus of the vagus. And when we think about this, we talk about reptilian rage when you've totally lost it. Now in freeze, when you freeze, when you're in this restorative survival mode, you can't access memories very well. You start having pains you can't interpret. You become detached and numb. But what happens is also that patients get stuck at the age of the trauma. So when these patients get upset with me, they are going right back to the feeling they had as children when they were being traumatized, but they think it's happening now. They don't look back at it and say, that happened to me when I was a child and now I'm 20 years older. They feel like this is all happening all over again, only I'm the perpetrator. Robert Scaer is a friend of mine, a neurologist in Colorado, and wrote several very good books about this kind of thing because he wrote about whiplash. And he saw all these whiplash patients. He couldn't figure out why these patients had whiplash because they give him histories like, I'm sitting in my car and it stopped and there's somebody rolling toward me at 2 miles an hour and I get bumped and now I can't move my neck or my shoulder and my arm is stiff. And he'd say, if whiplash can be caused by trauma that's as little as that, why don't all pro football players get whiplash? Why don't all rugby players get whiplash? So he discovered that patients get whiplash are in a situation where they feel like they are victims. They are about to die from this automobile accident and they can't do anything about it. Inescapable danger is what causes PTSD. That's the characteristic cause of PTSD. It's not the amount of trauma, it's whether you feel you can escape or not. That's why after 9/11, there weren't many cases of PTSD in New York City. You look at the pictures of 9/11, people are all running away. They can do something about it. They weren't trapped. So interestingly, for all that trauma, very low incidence of PTSD in New York City after 9/11. Now, the intermediate system you see in the autonomic nervous system, the fight or flight system. And the highest is the vagus nerve. And this is what you feel when you're in love, when your wife comes home, when you see your girlfriend, your heart flutters, your eyes widen, your voice changes to be more tender, your breathing quickens, your hearing gets more acute. That is the highest level of functioning. When my patients are going to sleep and they're nervous, I start talking to them and they look at me and I'm keeping them connected to my eyes so they don't go into fight or flight. They're not thinking about, I'm going to go to sleep and I don't know what's going to happen. They're connected to me and they wake up quietly. They don't wake up thrashing. That thrashing is because these patients are tied down and they think they're going to die. That is releasing trauma energy. Now, you don't have to do revision rhinoplasty to get in trouble with BDD patients. If you perform only primary rhinoplasty, your chances are still 0.5% of having a body dysmorphic patient. This was my own review of 1,000 consecutive patients some years ago. 4.5% of my patients had body dysmorphic disorder, but almost 12% required a lot of extra time, a lot more difficult to the staff. So the traits of BDD, we know these already: disturbance of body image, disturbance in the sense of who people are, a sense of being damaged. They are untrusting, many of these patients. They have distorted memory. They can't remember a lot of what you told them after surgery. They have what's called alexithymia, means they have feelings, but they can't tell you what they are. And they lose emotions as reliable signals. These are also the same exact attributes of PTSD and traumatic stress patients. If you look at all the literature, I have the advantage of surveying all of it. So I think these patients are medicating pain. You come out of your childhood feeling defective, and you can medicate it in any way you want. If your parents drank, you drink. That's your default method. So that's why alcoholism, quote, runs in families. You're selecting what you saw. You gamble, you become a sex addict, you become depressed, you get addicted to plastic surgery. So they're driven to seek additional surgery. What's hard to see that I used to distress me about these patients is they did not fear surgery or complications. Some of them would come to me having had multiple operations, multiple things going bad, and I couldn't even get them to hold still for me to tell them what might not go right or that they might need a revision. It's like, okay, let's book it. And they are actually happy when they're undergoing surgery. One patient said to me, I'm never so happy as when I've just gone through a cosmetic operation. And they are never satisfied. So I think what I'm trying to describe to you is a group of patients with or without deformities. Having a deformity doesn't mean you can't have BDD, and not having a deformity doesn't mean you have it. These are patients who had other surgeries starting at a young age. They have other health problems, all kinds of family trouble, and they're dissatisfied following surgery. So what I think is that, unlike the way we traditionally think about this, the unhappiness in these patients did not follow our surgery. It was there before they had it. It drove the surgery to begin with. This is a preoperative problem, which is why successful surgery often fails. This is, to us, what BDD is. The mental health diagnosis isn't helpful. Now, trauma is not just for revision rhinoplasty patients. If you treat morbidly obese patients, 80% of them at least have had childhood abuse or neglect. This is all over the body image literature and the mental health literature. It's not in the plastic surgery literature. And nobody who's doing bariatric surgery or body contour surgery writes about it. Addictions, depression, eating disorders, fibromyalgia, every one of these things, hand patients with chronic regional pain syndrome, every one of these things has been attached in the mental health literature to childhood trauma. You're seeing trauma. Now, in my book, I haven't written this up because my tests of resilience wouldn't pass muster in the mental health world. But when I scored patients for resilience, meaning how well they were running their lives, resilient patients with the same ACE score would still have better health. They were older at their first surgery. They'd had fewer operations. They weren't depressed, demanding, or perfectionistic, and they were much more likely to be happy. So that's why you can't use the ACE survey as a screen for surgery. Because trauma isn't the same to everybody. You can have 2 or 3 children in a family, same parents. Not all of them end up equally disordered as they grow up. I realized as I did these surveys that I couldn't judge someone's ACE score, even though I'd already operated on them. They'd come back post-op visit 6 months or whatever. I'd give them a survey, and then I'd look at it, and they checked 8 out of 10 things. And these were some of the nicest patients, the most happy patients, the easiest on the staff, successful people. Everybody in the office loved them. And I'd say to them, why aren't you a homeless person? Look what happened to you. How come you aren't a drug addict? And they all would say the same kind of thing. I had a grandmother. I had a coach. I had a teacher. I had somebody outside the nuclear crazy family who said, I believe in you. You can do this. And that neutralized the toxicity that went on in the family. So in the mental health literature, they've already connected, just in the last 2 years, trauma to body shame and body shame to BDD. So there are 2 papers in the literature, one 20 years ago that was never followed up, plus mine, that linked childhood trauma and body dysmorphic disorder. So adverse childhood experiences link to body dysmorphic disorder through the intermediary of body shame. So all of the things that I've talked about have a common origin in childhood trauma, all these self-harming behaviors and addictions. It just depends on which one you choose. I think someday body dysmorphic disorder is going to be attached to them. So the dissatisfaction began before surgery. The patients are not pretending. They don't know why they feel like this, but you can screen them for looking at for certain things. Immature behavior, non-compliance, poor moderation of their lives, history of obesity or poor self-regulation, patients who sound like victims. You know, that previous doctor, he butchered me and I'm going to get even with him. Patients who can't understand surgical limitations. So this is the way I look at this. I think childhood abuse and neglect is the soil. And then you get this shame core and you develop any of these things. If you look around that tree, every single one of those self-harming behaviors or addictions has been connected, as I just said, independently to childhood abuse or neglect in the mental health literature. This is my speculation. I think it just depends on which one you choose. If you choose body shame, then plastic surgery is why they come and seek us. So before I operate on anybody, I want to preempt a question if I can. I've always gone along with these 5 questions. I have to be able to see what the patient sees, and I have to feel I can personally fix it. I feel like patient has to be manageable. They have to be able to withstand the dressings and the examinations. They have to understand if there's a complication that I can manage them. And they have to understand that there's a margin of error that's inherent of surgery, even though they're seeing us who are surgical subspecialists. That doesn't mean my complication rate is 0. And I discussed that very candidly. And I look at the eyes of my patients. Now, these are the only patient slides I'm going to show you. And I'm going to show you 2 groups of patients, and I'm not going to tell you anything about them. I just want you to look at the eyes of these people, and you can decide for yourself what they mean or what they might have meant in my practice. These are preoperative photographs. They all happen to be secondary rhinoplasty patients. But these are, I sit the patient, I take the pictures myself. I sit the patient and I say, let me take your pictures. Just sit on the stool and look at me. And you'll see these eyes. Now look at these patients. Some of them are defocused. They're not even looking at me. One woman has her eyes closed. Now this is Tim Allen. Just yesterday, he posted on Instagram how he's been sober for 20 years. Look at his eyes before. This is another woman who just posted yesterday. She's been sober for a year. If you follow body dysmorphic patients on Instagram, their eyes are the same. The sobriety patients, their eyes change when they get over their addictions. Now look at these eyes again of my patients. So I've added these criteria for surgery. I want patients, and many of you know this intuitively already, how do they engage? Do they look at me? Do they listen? Do they laugh? Are they using their social engagement system? Are they using the nucleus ambiguous part of the vagus nerve? Now you know all about that. How well do they listen? That's also above the diaphragm. Do they make good decisions? How cooperative are they during examinations? Do they yell? Do they interrupt? Do they talk over me? Is there a protective person by someone, by that I mean some adult or some spouse who talks over the patient, who tries to control the interview and tell you what the patient ought to have. I had a woman come in with her son who was 40, and she said to me, "We don't want a bump on our nose." What kind of family is that? How does the patient react to this discussion of potential complications? You have a tertiary patient and you say, "I think I may need to take ear cartilage," and they begin getting diaphoretic, you've got a problem. And your own gut, that's you, when you say your gut bothers you, that's your own dorsal motor nucleus of the vagus. It's your own subdiaphragmatic, restorative, last resort survival mechanism that's warning you. Don't ignore it. Gut feelings really mean something. And leverage. And I mean by that, The only leverage you have over patients in asking them to do something, asking them to get a mental health evaluation, asking them to get trauma work, asking them to wait longer, asking them to do anything is before surgery. Once you operate on them, they have leverage over you. So it's very important also to set boundaries after surgery, because they will tie up your staff, be on phone calls all the time. They'll listen for catastrophic language. I miss about one of these patients a year still, as careful as I am. When the patients start saying, I'm ugly, disgusting is a particularly bad one, repulsive, horrible. These are not words people should use about themselves. That's language they heard as children. That's why they're using it. When these people who are immature get stressed, they go back to being children. That's why they think the swelling is never going to go away. Remember, when you have young children, child falls down at age 4 and skins his knee and starts crying. That child thinks that pain is going to last forever. So I used to say, wait a minute, wait, it's going to stop hurting. And sure enough, in 15, 20 seconds, it stops hurting. And the child learns that. Some patients never do that. They go back to childhood brain. Do reversible procedures. For me, that's the advantage of my endonasal work without any permanent sutures. Don't do an operation you don't believe in. That's how people get in trouble. And remember that what they say isn't about you. So now you know what you have to do to eyes like these to make them into eyes like these. This is the cover illustration for my book done by Rustin Sanchez, who just finished his plastic surgery residency at the University of Wisconsin. And I think he captured very well that PTSD, they call it in PTSD literature, the 1,000-yard stare of the patients that I showed you. And that to me capsulizes the way a lot of the most troublesome patients we have look and behave. So thank you all very much.
Sure, Mark, I've got goosebumps listening to you. I mean, we've had some remarkable speakers, but what you shared with us is it's almost life-changing. You know I spoke to you earlier about a book by Bessel van Kolk called The Body Keeps the Score.
Yes.
And that was fascinating to read about this, but it's mind-blowing what you've shared with us. Eh?
Yeah, he influenced me a lot. In fact, when I was doing my research, he teaches a summer course and on Cape Cod, and I went and talked to him and took his course for a week. He's fascinating. He was the one who first described PTSD, as you know, from reading it in Vietnam veterans and Boston at the VA, because he realized that these people were all having flashbacks and arousal and avoidance. They didn't want to think back to it, and they would get upset. In fact, in my book, I had never published this because I didn't have time to write it up, but it would have made a good paper. I screened 35 patients of mine, secondary rhinoplasty patients, for PTSD. And about 60% of them actually had PTSD. They still could take themselves back to the experience of that surgery, and their heart started pounding, and they tried not to think about it, and they had nightmares, and they had flashbacks, all the PTSD symptoms. And after I operated on them, it virtually always went away. And the people who got it out of this group were the ones who had childhood trauma. So that also fits in with the literature, because there are papers showing that soldiers that go into battle that get shell shocked or PTSD, that doesn't depend on how bad the battle was. It depends on the mental health, if you will, and the sense of well-being and of personal strength that the soldier has going into battle. So it's the resilience aspect. Now, you asked me about a patient. I added a slide on here for you.
Thank you. That would be great.
Just because I want to close this out and stop sharing. But I did have a patient like this. She's in my book, as a matter of fact, in the whole letter, just like the whole letter of that young man with the childhood trauma. And I operated on her, and she came back. It looked good to me. It was a rib graft. I'd restored her original nose. She was from Italy. And if I had let her, she would have come back every month to be followed. And she was a mathematician, very educated woman. And afterwards, she said, "This doesn't look right. It looks all wrong. My nose is too wide. It's too short. It's blah, blah, blah." So I said, "Let me send you your photographs." This is before I knew any of this. And this is where I say you can't reason with these people because they're not coming at you as adults. They're coming at you as children. So I sent her photographs, pre and post-operative, and she drew out all the angles on them and labeled the base of the alar lobule on the left was alpha, the one on the other side was beta, all the way through. And she said, now we have a trapeze. She means trapezoid, ABEF on top of a rectangle, EFCD. And she had a full page of a mathematical analysis like this to show me what was wrong with her nose. And then she concludes by saying, but I'm sure that you're the only surgeon to help me. So I did not operate on her again. And I was actually at a meeting and presented her. And Jack Gunter said to me, I saw her and I refused to operate on her. So he was smarter than I was. So anyway, those patients present a particular problem. I know your patient is a mechanical engineer and has brought you something similar. So I can discuss that with you a little bit if you like, but I don't want to preempt the discussion. I just wanted to bring that one patient out because it was so parallel to the one you wrote me about.
Okay, well, there's just questions pouring in here. So I'm just I know, unfortunately, I got kicked off for a minute in between. So one of the first questions was in terms of, is BDD a, I can't find it here, but they want to know, can you operate on a BDD patient or should you rather not?
The trouble I have answering that is I didn't test any of these patients for BDD. That's why I've got to call it surgical BDD. And these patients, a lot of them wouldn't qualify for BDD as it is in the literature because they don't have imaginary deformities. That's where I get stuck because I see these patients, even if it's operation number 6, and they started out with totally normal noses, now they really do have deformities. Now they really do have airway obstructions. And so I don't look at it as this person has BDD. I say to myself, can I make this patient happy? Can I fix this problem? Not is this patient lovable, but can I get them through it? And so they can cross this problem off the list. They may still be sort of depressed people who aren't the spice of life, but can I make the nose not part of their problem? And some of those I'd say yes, but you have to be very careful. If it depends on what the surgeon means by BDD. If you've got someone who comes in with a parent who does all the talking and they're acting infantile and you can't get them to hold still while you discuss the complications and you tell them something and then they ask the same question again, they're not even listening and you can't get them to smile and connect with you, that's bad. So I have to think as a surgeon in terms of the functionality of the patients we see. Because when I was on a panel with a BDD expert a few months ago, she said, well, don't operate on patients who come in with their hair combed over their noses in camouflage. Well, are you kidding? None of us is going to do that. That's not our patient population. Our patients are employed, functional people, often on very good behavior, who come in wanting surgery. So we can't look for delusional patients who say, I haven't left my house for 3 months because of the way that I look, and my boyfriend left me because it's my nose. We all pick out those patients. So I think it depends on what this surgeon means by BDD and whether he or she can handle the problem.
Okay. Another question here from Charles Varley would like to know, please could you share your experience with dealing with Simon syndrome, demanding primary rhinoplasty, and how to categorize them and choose for surgery?
Well, I think the Simon is a Mark Gorney, he's a late Mark Gorney acronym for the immature young single male. And he was really describing a lot of these, the characteristics of these patients, only I didn't find a dominance of male patients. He was describing a lot of them unmarried, a lot of them narcissistic, meaning you can't connect with them and everything is all about them. And so they really do describe the prototype of the difficult patient. But again, I think it goes back to, can you communicate with these people? Are they listening to you? Can I personally fix their problem? Not have I read something somewhere in a journal that I might try. Do I know I can fix this patient's problem with a high level of certainty? Then I think you can do it. I will often modify an operation. I had a woman come in who kept crying through the consultation. She really had been hurt. She had a straight nose. She went in just to have her airway done, and her doctor said, how about if I make it just a little prettier? And she came out with a collapsed airway and notched nostrils. Profile wasn't too bad, but every other minute in the office, she starts crying. And yet I thought, I've got to do something for her if I can. So I said, she had no septum. I said, let me do ear cartilage spreader grafts and composite grafts, so I can open your airway and bring your nostrils down, so from the front you look normal. Now that's a very high percentage shot for me. I know I can make it work. And so, and that's all I did. I didn't touch her profile. And I got her through it, and she was a little worried, but she was cooperative and she was very grateful. So I modified what I did to something I knew I could produce for this patient with a almost certain success, recognizing that her ability to tolerate another problem is not very high. These patients are wrung out when they see you. They spend a lot of money. Everybody ahead of them has said, don't worry, sweetheart, I can fix this, and has not fixed it. So my wife often says to me, these people's prior experiences were so bad, I don't know how they have the guts to come to see us. So do something that you really can control if you feel it's a patient you can work with.
Sure. Dr. Indu would like to ask you, do you advise referring the patient to a psychiatrist routinely before surgery if you're suspecting BDD?
If the patient will accept it, I will refuse to operate on patients, and I'll tell them why. And I'll tell you how I refuse also. I have had a man come in who was still extremely angry, and he was very candid with me, and his nose was badly broken before the first surgeon operated on him. And he said, my nose was broken by my father who used to beat me. And the result was good. Not perfect, but it was good. And I said to him, you're still too angry to have surgery, to go through another stress. You need to go have trauma work first. And he came back a year later, much, much better, and I did operate on him. So I will refer patients if I think they will take it. You have to have someone who's interested in this. Not every mental health person understands trauma. I mean, if they're going to give them antidepressants and do cognitive behavior therapy, it's going to have, I think, limited effectiveness. And the reason is this damage is done to the immature brain. This damage is done before the cortex comes online, which doesn't start till age 6 and keeps going till 21. So you can say to a patient all day, your mother told you you were worthless, but look at you, you've got a successful business, you're not worthless, see? And the patient will say, yeah, I guess I get it. They don't leave the office feeling any different. You can't logic trauma out of people. You have to treat the area of the trauma. So if you have someone who is a good trauma therapist and goes to the area of the injury and treats that, then that's good. Many patients are positive this is a surgical problem, and I have often been unsuccessful in getting these patients to surgery. I'll preempt another question and kind of segue on the one you just asked, which is how do I turn down patients I don't want to operate on? And this is whether they're my own patients or someone else's. If I think they'll take my advice, I just say so outright. But some patients, I just don't think it's good for me to operate on again. And I think they're going to make a scene. And so I'll say, let me take photographs and I'll think about it. That allows me to document how they look. And then they leave the office and I do think about it. And I write them a letter and I say, this is what I see. This is what I hear from you. either I don't think I'm the right surgeon to operate on you, or I don't think you should have another surgery because I think the likelihood of a good result is not good. I don't say ever, I'm not smart enough to handle your problem. I've heard surgeons give that advice. And I think that's bad, because I do know the answer. If I say, I don't know, I'm not smart enough to understand your problem, that invalidates any advice I might give them. And if I think this patient can't go any further without having a catastrophe from another operation, I think they ought to know that. And I want them to believe me.
Philio's got a very interesting comment here. She wanted like to ask, how are you advised to ask personal questions like child trauma and abuse?
Sometimes it comes out spontaneously. If you remember, the test I gave was all postoperative patients. And that's been the flaw, I think, in some studies in plastic surgery literature on the psychological makeup of plastic surgery patients, because they're given as preoperative screens. And the patient sitting in the waiting room knows he or she has to give the right answers because they're afraid of being rejected for surgery. These patients of mine there was nothing at stake, so they could be honest with me. I know the literature pretty well now, and so sometimes it will come up. What's interesting is there's a prevailing feeling among primary care doctors and a lot of physicians, you can't ask these questions. They're too personal. And I wouldn't bring it up out of the blue without any connection. But a patient comes in and tells me, and I'm interested in my patients. I'm in private practice, so I can take a little extra time if I want. And nobody can, shove the next patient in on me. So if a patient comes in and they've had bariatric surgery and body contour surgery for being morbidly obese, and I know that the prevalence of childhood trauma is very high in those patients, I will say, I have said, that's very interesting. According to my reading, people who've been morbidly obese have often had very rough childhoods. And often the story starts spilling out. Oh my goodness, they start telling me all of these things. And then one woman started telling me all the abuse she'd gone through. And then she stopped and said, you're the first person who ever asked me this. That's a shame, because she's got a primary care doctor. She's had plastic surgeons. She's had the therapist she had to see before she had her bariatric surgery and went through that screen. And nobody has covered these problems. These patients, I had thought when I started this study that patients wouldn't want to do it. Nobody turned me down and in taking the survey, and nobody was embarrassed about the score. I mean, we gave first, we'd say, okay, fill it out, turn the paper over, put this into an envelope that my wife is holding, and nobody will see your score. It wasn't like that. Patients would go to my wife, who's my office manager, and show her the paper and say, did I get a good grade? I mean, they were eager to unburden themselves. So it's not dangerous if you think it's worthwhile and there's a natural entrance. If someone says they were beaten or they're in an abusive relationship, there ought to be a medical reason to ask this. I wouldn't do it as a screen, but it's not verboten to talk to people about their childhoods if you can, because they're frequently happy to tell you.
Philio's got a second part also in a comment. She asked here, how many times do you see your patients before surgery? Surely we need more time than the one-to-one consultation allows us to get some important information.
I was trying to unblock my picture. So I think, did you say to me how many times I see patients before surgery? Is that the question?
The question really is, surely we should see patients more than just once.
I do, but I don't drag it out. I allow an hour for a secondary rhinoplasty patient, and I'll take more time if I have to. I don't always have to. And then I get photographs. And if the patient schedules, I write a letter to that patient that's on blue paper. It's called a blue sheet. The first page is boilerplate. Surgery doesn't guarantee good results. It guarantees the best the surgeon can do. There are uncontrollables and so on. Things you want to tell every patient. But the second page is one I have personally dictated based on the patient's notes. You have had 3 operations. You had airway obstruction from internal and external valvular incompetence, your nostrils are retracted, and blah, blah, blah. And this is also what you don't like cosmetically. And this is what I need to do. And these are the donor sites. And this is the chance that I might need to do a secondary procedure if you want the best possible result I can provide. And we send that to the patient. And that copy goes in the patient's chart that's signed by them. And I see them again before surgery. They've already gotten the blue sheet now. And I put their patients out in front of the photographs out in front of them, and they read the blue sheet, and I say, okay, here's your pictures. These are the things you told me about. This is what I'm going to do. Have I missed anything? They do get a second consultation, but the second one is really at the H&P, and it's 20 minutes. Now, I also score patients when I first see them from 1 to 4 based on how comfortable I am with them. A patient who gets a 3, I'm worried about, and I'm not going to schedule those patients without a second consultation. And a patient who's a 4, I'm not going to operate on, period. And my staff knows if they call up, they're going to say, Dr. Constantian doesn't feel he can help you. So those some patients will get a second consult, but I don't have that many 3s, because if a patient makes me that uncomfortable, particularly at this point in my life, I don't want to add complexity. So they got plenty of chances to interact, because
So,
I want them to know we're on the same page, particularly people who've seen a lot of doctors.
Yeah. Sarah Khan would like to know, do you prefer screening every patient in the clinic coming for aesthetic surgery with a validated screening questionnaire for BDD?
No, I don't. And I tried a screening questionnaire for Kathy Phillips, who was a psychiatrist. Now she's at Cornell. I've known her for many years. And she's one of the world's experts on this. In fact, it was her papers I ran into first. And she developed a BDD screening questionnaire that she'd used in a cosmetic dental practice. And she asked me if I would try it. And I tried it on 50 patients, but I thought it was not useful because the questions were too transparent. You know, do you think about your nose more than 2 hours a day? It's like putting the ACE survey in front of these patients. They know if they sound crazy, I'm not going to operate on them. So I thought it wasn't good. I really have to go by my own instincts. That's also the reason I wouldn't rely on a therapist to tell me whether I should operate. Because if my gut says no, even if the therapist says, no, sweat, this patient is fine, I don't think I should operate. But so, you can't use them with the ACE questionnaire for the reasons I gave.
So I'm just thinking aloud here. I mean, one of how can I put it, like Jack Gunter's diagrams have gone down the annals of rhinoplasty. I think Sam Most's nose questionnaire is probably it's also one of the main questionnaires. But Mark, haven't you considered that maybe with your experience of 30, 40 years of rhinoplasty and this exceptional insight to the psychology of it, would you not be able to try and give us as rhinoplasty some kind of a questionnaire that we could look at, you know?
Well, in the paper I'm writing up, I list the characteristics, a lot of which you've seen. Something like that to really be good would have to be tested for validity, you know, for you know, specificity, and I, you know, so I'd need to take it, make it up, take it and give it to 100 patients and then see how well it did. So I can give guidelines based on logistic regression. I can take all the things I looked for and said, okay, if we start with the endpoint of these patients were not happy with what I did for them, these are the things that keyed into that. And they were the ACE survey, although that wasn't that strong. Patient who said she was a perfectionist or he was a perfectionist. Patient who was depressed, but before any of those things, it was body shame. Those are the patients. If they tell you the things in that 4-question screen, which I have in the book, or I can send to you, or it'll be on this presentation once it goes up on the internet. If they say those things to you, I would be very careful, because you're now dealing with someone who is not just dissatisfied. They feel shame about the way they look. And you can sense that, I think, as you talk to these people. You know, there are patients who just strike you. I think we all can recognize the patient who has confidence without being grandiose, and they're pleasant and they're rational and they listen and they relate and they get it. Those are the people who are thinking like grown-ups. You have to operate on grown-ups. Traumatized patients are not coming from a grown-up place. They're coming from an immature place. That's why they behave like they do.
Okay. Alessandro would like to know, Dr. Constantian, adult patients who enter the office accompanied by their mother, would that be an alarm signal for BDD? How do you deal?
It depends. Some patients need that support, or the mother has driven them, or the spouse has driven them. If it's a teenager, generally I see those patients first by themselves. And then I bring the parents in, because I don't want the parent controlling the conversation. Sometimes it's like a ventriloquist act. You know, you ask the patient, the mother answers. I don't want that. I want to hear it from the patient. But the way the patient interacts with the spouse or the parent tells me a lot. When the parent is sitting there, if the parent's quiet and listening, and the patient at the end says, "Mom, do you have any questions?" and the mother says, "No, it sounds fine," that's fine with me. That's a grown-up relationship. If the husband keeps overriding what the patient wants and saying, "Well, I think this is a stupid idea, and you also told me this or that, and why don't you ask him about this?" or the mother is interrupting, and the patient keeps saying, "Stop it, Mom, stop it." That's not a good relationship. So I think you can get information out of it, but if it's a teenager, older teenager, I would say, not 11, but a rhinoplasty candidate that's 14, 15, 16, 18, a lot of times it's much better to see them first. And my staff is very clued into this too. Sometimes they'll say to me, you know, this is a college kid, and his mother's filling out his form for him. So then, you know, we'll see the kid first, and sometimes he will open up the minute mom comes in for the rest of the consultation. All of a sudden, he becomes mute. That's bad. So I think, sure, see it, but make something out of it.
Thank you. A comment from Farid. They'd like to know, or Fernando at least, have you referred any of your patients to a psychiatrist or psychologist so that he or she could find a way to treat their post-traumatic stress?
I have on occasion. I live in a smallish town, and I used to have someone who was retired who was very interested in this. You have to have a therapist who's really keyed into this, into trauma work, and many of them are now, the ones who've been influenced by Van der Kolk and his writing and the other people. And so that's a wonderful book. The Body Keeps the Score, is that right? I think it's a fantastic book. It's long, but it's really like an autobiography of his life's research. And here's another thing, talk about not being able to get a new idea accepted. Childhood trauma, which they now call complex trauma, is still not in the DSM-5, even though Van der Kolk has submitted with other authors tens of thousands of cases with data to the committee that makes up the DSM-5. This is the party line in mental health. They would not take it. So you have to find people who understand this. I mean, he was super frustrated. This had just happened when I was taking his course, and he couldn't believe it because the literature is filled with childhood trauma papers, hundreds and hundreds of them, and he couldn't get a code for it. So complex trauma is the daily battering, you know, the emotional abuse every single day, the small t trauma as opposed to the capital T, where, you know, your house burns down. The small t is much worse. So if you've got somebody tuned in, I think that's good. But I think as a surgeon, let me say, I use it to help the patient. I don't use it to help me decide whether I'm going to operate.
Wow. Okay, can I just briefly share my screen here? I just want to show you the picture that I had emailed you that we spoke about briefly. Here about this patient. So I just want to give you a little history again. 29-year-old mechanical engineer, comes in, opening line is to say that she wants the surgery so that somebody would propose to her, and then burst out laughing and said to me, I read the article you wrote in the aesthetic magazine, and you said that one of the reasons we shouldn't have surgery is it's not going to really change our lives too much. So clearly she had quite a good understanding. And the things so I put this on Instagram, and a lot of people said, red flag, red flag, red flag. And I thought, let me bring it up tonight because it's a good discussion to have. I personally actually don't feel it's a red flag, because I thought that she was, yes, she's single, but she's an older girl. She hasn't had any surgery before. She was quite open to discussing that we wouldn't get the perfect results. But to me, the way she'd written everything down was her way of thinking, of being more like an analytical engineering discussion. So I'd love to hear what your thoughts are on this.
What does her nose look like? Can you get this shape? Will her tissues do this?
I've got it on. I haven't asked her permission to share
But I mean, will her tip lobule come in that much? Can you get a dorsum and that much retroussé out of her tip?
She can do with a tip refinement surgery and narrowing her nasal bones. I think we can really improve her look. But it's one of those patients who it's going to improve, but it's not like this massive dorsal hump we're going to take down. It's more finesse surgery.
Yeah. Well, but she's not looking for improvement. She's looking for that picture. That's why I asked you, will her, she's got a tip lobule that is a lot smaller. And if you can't deliver that, she's going to come back with holding the picture. That's what I'm worried about. Did she say to you, she wanted this? Did I hear you right? She wants this operation so somebody will propose to her?
Yeah, but she did that as a tongue-in-cheek at the start.
Oh, okay. All right.
Because we mustn't do that.
Yeah, I've had that, because I actually had a patient come in and tell me she wanted surgery because her boyfriend had left her because of her nose. I was engaged up till last week, she says. And so, I mean, I obviously never operated. I think I'd be more inclined not to than to, only because, but I'll have to say, I mean, you have to judge. I haven't met her. The first question is, can her tissues take this, and can you do it? And I don't mean that as an insult. I mean, not every nose has the right kind of balance. If she's already got a large bottom heavy nose and you try to get that much retroussé, that much projection of the tip beyond the dorsum, it's going to look bizarre. And on front, the tip lobule has to come in a lot. Not everybody's soft tissues will do that. Most patients' soft tissues won't do that. So that's one thing. Second, how did she react to your patient examples? Patients often come in and they're very specific. And I've had patients for years I say, bring in photographs of what you'd like to look, how you'd like to look, which many surgeons think is so suicide for the surgeon. And I've never had a problem with it, because I use it as a teaching guide. I'll say, okay, this woman's nose is much smaller than yours and it's much narrower. I can't do that. But you've got a bump, I can give you a straight bridge with better proportion. You've got a very round tip, I can give you a tip that's much more angular. I can give you a better airway, but it's not going to be little like this nose, because your face isn't like hers, your eye color isn't. And some of them, oh yeah, I get it. And I've never had a patient come back and say, this is the picture I showed you and you didn't do it. So if you can use it as an educational tool, that's helpful. And then I will put out the pictures and say, okay, here's someone with thick skin like yours that wanted what you want, and this is the best I could do. This is you. Because usually I've been 42 years in practice. I can pretty much come up with a duplicate of anything someone brings me. So I'll lay it out, I'll say, this is your nose right now, and this is what I did. And some will say, oh, that really looks great. And I say, well, but it's not as small as what you wrote me. But it looks so much better. And others will look at that, they say, which one is the before? Or that's the best you can do. You're the subspecialist and that's the best you can do. So all that gives you information. Now, she might do this for a couple of reasons. She might do it because she's an engineer, and a lot of engineers don't get that our world isn't like theirs. And I'll say that, my world does not work in millimeters, because the tissues move during surgery and I don't control how much things contract. And some will get it right away and they say, all right, forget the drawings. And other patients, particularly secondaries, will come in with all this information because they feel like the reason the other operations didn't work, or the reason their friends have all had bad results, is because they didn't tell the surgeon enough. It was my fault. I didn't tell him exactly what I wanted. And so they figured, now if they educate me and they tell me everything, then I'll get it where the last guy didn't get it. So those are two reasonable reasons why people might do it. But you know, your gut will tell you a lot, but I think you've got to feel like I do, that with a fairly high security that I can deliver that. And you know, that our tissues will do it. Because that you can't control. You know, her skin sleeve is what it is.
One of our participants here is just saying about how good this has been, and he's also been doing rhinoplasties for 30 years. And thank you very much for all you've spoken about.
Thank you.
Yeah, and then a question again from Filio, interestingly enough. Oh, she's actually speaking to me about 3D printing for the girl, because she'll be interested because she's a mechanical engineer. Okay, Mark, can I, our signature question at the end of every talk we've given is I've asked the speakers if they could leave us with their top 3 tips. So I'm kind of putting this on you. I didn't warn you beforehand, but if you
didn't. Thank you very much.
Everyone is listening to you. What
That's
would
right.
for you the 3 most important things in rhinoplasty that you'd like to share with us?
If you're talking about this group of patients, how to avoid unhappy patients. And this is not going to be bulletproof, because as I said, I miss these patients occasionally myself. The connection is very important. They have to listen. They have to have something that you can personally fix, and you have to see it with the same eyes they see it. If they describe something as huge or disgusting or horrible, and it doesn't look horrible to you, that means they're adding something in their reality that isn't at all like your reality. That's a danger sign. So you have to see it the way they see it and feel confident you can fix it and have a really good connection. And then this is for a primary patient. And then if they're revision patients, you need to look at their history. When did they start having surgeries? How many other operations have they had? Are the reasons they're unhappy reasons that you would be unhappy also? How do they feel about the prior surgeon? That's important, because some patients will come in and they're mad because the last surgery didn't work out right. And I'll say, you know, I know this doctor, and he or she was really trying to do the best surgery they could. Or I don't know this surgeon, but you know, most doctors are really trying to do the best they could. And the patient will say, yeah, well, you know, he really was upset and he wanted to pay for the consultation to see you, and they need to be educated, and I need to get the temperature down a little bit. And if they respond to that, then I say, okay, I can educate them about how difficult rhinoplasty is. If they say that SOB and I can't get them around it, then that's a bad sign, because I'm next in line to be the SOB and I don't want that.
Sure. Well, it's a pity that we got to end. It's been absolutely fascinating. Thank you very much. And thank you to everybody for listening. Next week, we are back towards facial plastics with Steve Perkins speaking to us on facelifts, and 2 of our South African colleagues as well. So that message will go out in the week. But yeah, Mark, honestly, from the bottom of my heart, thank you so much for this. We really appreciate what you put in, and I really hope that all of us are going to be able to have some new tools that we can take into practice with us.
Well, thank you. You can certainly get more information. You know where to do that. I appreciate the audience. This is a topic that almost never runs out of depth, and I appreciate the invitation, Cam, very much.
Right. Thank you very much. Good night.
Good night.